Good morning, everybody. First, my sincere thanks to Vadim for the very kind invitation. I come here among friends, which is really important to me, so I'm very pleased to be with you this morning. I would like, those are my conflicts of interest. I would like to actually share with you this morning a little bit of a background. Here it will be shorter, you will see, but in the second lecture it will be a little bit longer. And I will discuss the role of insulin pump therapy with you, the role of continuous glucose monitoring and the combination. I will touch cost effectiveness, which I know depends from country to country, but it is an important issue. And I, of course, will also touch a little bit on the closed loop, but we'll discuss it more in my second lecture. So the background. The background is that even in the best countries in the world, for instance, Sweden, people with type 1 diabetes are dying sooner. So this is actually a 17 years difference in mortality. Yes, so a 17-year difference in mortality here if you get type 1 diabetes before the age of 10. And this, of course, this is not a bad country. This is Sweden, one of the most organized and rich countries in the world. So diabetes still is a deadly disease. We didn't do much progress because exactly the same difference in mortality actually was true 20 years ago. So interestingly enough, with all the improvements in technology, the mortality gap still persists. And also, this is a paper of the rich and the beautiful. So look who is starring here. So Sweden, Germany, Austria, Denmark, Norway, England, and the United States. So the best countries, right? I'm sorry. And yet, as you can see, actually, the control is suboptimal in most of them. And this is the mean A1C for the Slovenian population of type 1 diabetes. Any of you are participating in the SWEET database? Can you please raise your hands? Is anybody a participant in the SWEET? So actually, SWEET is now an international database of type 1 diabetes. As you can see, there are centers from all over the world participating. And actually, the most concentrated is still in Europe, but the most important part of it is benchmarking. If you are a participant of SWEET, every year you get a report on how you do. And here, as you can see, I'm sorry I cannot show it to you, but here actually is Slovenia in the green field. We are still not happy with it, but every year we try to improve. So this benchmarking is really important. As you can see, actually most of the European centers participate in this database. And you are all invited to SWEET. SWEET is open to everybody. So if you have a center that has type 1 diabetes, you're very welcome to join SWEET. Just Google SWEET on the internet, and you will see what I am talking about. Now let's move a little bit to the pump story. So the pump story actually started long ago, as you know. I will focus on the last couple years. So this is the type 1 exchange study, the first study that they published in 2014. And what they showed actually is that everybody that is switched from MDI to pump improves. And this was true for different age groups, as you can see here. And the longer actually the duration, the better. Here the data is cross-sectional difference was 0.6%, and the longitudinal difference with the follow-up each year there was a decrease of 0.2% in glycosylated hemoglobin. And then the European data started. This is a Danish registry. Danes were very slow with pump adoption for some reason. They were probably one of the last pump adopters in Europe. Yet when they did, actually, they also showed an improvement in glycosylated hemoglobin in every age group in type 1 diabetes. And then, interestingly enough, actually, another Danish study was published a year after. This is an adult study. And really, the Steno Center, this is from the Steno Center, they were really resistant to pumps. They really didn't want to use them. And yet, when they did, actually, as you can see, there are almost 200 patients in the pump group and almost 400 patients in the MDI group. And yes, as you can see in the upper left corner, A1C consistently improved, even in Denmark, in the Steno Center, when they started to use the pumps. What was maybe more impressive to them is that here, as you can see in the lower part, the urinary albuminuria improved. So pump use was able to reverse a chronic complication of diabetes. And this is very interesting, and we will actually come a little bit back to this important data. And this was also true when they adjusted for several confounding factors in this study, as you can see in the lower part on the right-hand side. Finally, this interesting study was published again from the Swedish registry in BMJ. And importantly, these two groups actually, one has 2.4 thousand people on pumps, and the other has 15.5 or more thousand people on MDI. There was no difference in glycosylated hemoglobin. No difference in glycosylated hemoglobin, yet a huge difference in mortality. People that used an insulin pump died less. Now we can discuss why the mortality is lower with an insulin pump. And there may be several reasons, but the sheer fact is, when you do the statistics, as you can see, if you use an insulin pump with a comparable A1C, you die less. And with no difference in A1C, which is really important because we try to be so attached to this A1C, and I will challenge this attachment to A1C throughout my two lectures. Similar data also come from a pediatric study from Australia, from Sydney, where Kim Donahue again demonstrated that with the same A1C, no difference in A1C, the retinopathy and the peripheral nerve abnormalities were significantly lower in young people. They were around 20 years old that use an insulin pump. So no difference in A1C, but an important difference in chronic complications of diabetes. And finally, there were some discussions about the ketoacidosis with the pump. And I think this study published now 2 years ago in JAMA really clarified it. So this study actually had two cohorts, the matched cohort and the entire cohort. The matched cohort was 10,000 people in each group, and the entire cohort was 15,000 people in each group. So it's a huge study. It's a huge study. And when they did the analysis, what they showed is that in the matched cohort, as you can see, severe hypoglycemia, hypoglycemic coma, DKA, and severe DKA were all significantly lower with the use of pump. So there were some people teaching that you need Lantus with the pump. Of course, this is a ridiculous stupidity. When you use the pump, there is less DKA and less hypoglycemia. And this was true in this large registry, in a matched cohort and in the entire cohort when they did the analysis. How's about CGM? Well, CGM is probably an even more successful story. How many of you are routinely using CGM in your practice? Can you please raise your hands? 1, 2, 3, 4. Oh, yes. Quite some, quite some. Excellent. Very good. So actually, when we actually nowadays the consensus of the American Diabetes Association and the European Association for the Study of Diabetes actually claims that CGM is a routine technology. And what's more important is that in their guidelines, the 2019 standards of care, actually they say that it's a useful tool. It's a useful tool. However, interestingly, we have no targets. We don't know what we want to achieve with CGM. And we will briefly discuss this later on. It all started with this study. So this landmark study published in 2008 basically demonstrated 300 subjects randomized to either CGM or to standard of care, which was self-blood glucose monitoring, demonstrated that after half a year, there was a very significant decrease in glycosylated hemoglobin. So this was the first large trial published in New England Journal that really set the standards for this therapy. Interestingly enough, this was only true for the adult population. When we analyzed separately pediatric population, there was no effect. And the question is why? And the reply actually is in this paper that was published just months after the original paper that analyzed children that actually used CGM. And when they separately analyzed children that used CGM, as you can see, children that even better than adults. And the second important message was that if you do not use CGM, it doesn't work. So just having CGM is not enough. You have to use it. And then, of course, several other studies, particularly those focused on hypoglycemia, started to emerge. This is history. This is the famous DCCT that actually should be more or less forgotten by now. Why I'm saying this? Because the reality is this. The 2008, which is also 11 years old, study demonstrated that in modern world, hypoglycemia is not an issue anymore, not even with lower A1C. Here you have pediatric and adult studies, and as you can see, actually, severe hypoglycemia is way down with the use of CGM. So a huge difference when you compare this to historic DCCT data. The first study probably that has the primary outcome, hypoglycemia itself, was our study at that time with the navigator when we were randomly, randomized people on MDI, on multiple daily injections, or either CGM or SMBG. And we were able to show actually that the time in hypoglycemia was reduced by half. At the same time, we was also able to show that the time in range was increased. And at that time, we didn't know what time in range was. We didn't know it was important. This is 2011, so it's 8 years ago. Yet we did calculate it and put it into the paper. The next study actually that we did was focused on A1C again, but at the same time, we also demonstrated an improvement in time in range. It was a crossover design, and you will see this graph that we published in 2012 into a very modern version really soon. And then it was actually the Libre epoch. And the first randomized controlled trial with the Libre was done by Jon Bolinder. And it was again a hypo study. And in this hypo study, of course, they demonstrated less hypoglycemia with the use of Libre. But also, importantly, time in range was increased. And also time in hyperglycemia was decreased. And when they asked Swedish people, do you prefer, what do you like more? Do you like more that your hyperglycemia was reduced or your hypoglycemia was reduced? What do you think they replied? Were they happier because of reduction of hyper or because of reduction of hypo? What do you think? Who thinks it was hypo? Please raise your hands. Who thinks it was hyper? Okay, it's approximately half-half, right? So Swedish people are very well educated, and they know, as I will show it to you later on, that it is hyperglycemia that's really dangerous, because it causes brain damage. So they were happier to reduce hyperglycemia rather than hypoglycemia. And then the big trials with self-standing CGM emerged, all in 2017. So the first JAMA paper, actually a randomized controlled trial with MDI and CGM. And here, as you can see, this is the baseline data. This is week 12, and this is week 24. As you can see, a big difference in glycosylated hemoglobin. So a small change in the control group and a very large change in the group that used the CGM. And this actually was true because of the high usage. Again, you have to use CGM. They used it more than 6 days, almost 7 days a week, actually, in order to obtain such a good result. And also, actually, when you check by subjects that reach more than 1% of reduction, which is a huge success. As you know, very few drugs can reduce glycosylated hemoglobin by 1%. But CGM did, actually, as you can see, considerably more with the use of CGM. And also elderly people, people above 60, were as successful as younger people, which is also an important finding of this study. And finally, of course, time in range was increased, which again, I will repeat it so that you get familiar with this new clinical target slowly, step by step. Hypoglycemia also decreased any threshold that you want, either below 70, below 60, or below 50. But then the next actually quite interesting trial was performed when they added to this study in the end the use of a pump. And interestingly, the use of a pump additionally improved time in range for approximately 80 minutes a day. So a good hour and a half actually, in addition, were these people in range when they used a pump. There was slightly more hypoglycemia, but considerably less hyperglycemia again, meaning that the glucose variability was reduced with the use of insulin pump in addition to CGM in this trial. And then the over-the-pond trial was published in the same issue of the JAMA journal. One was done in Europe, the first one, and this one in the United States. And again, the very same result. This was a crossover design. As you can see, when the group in purple here was using CGM, the A1C dropped very significantly. And then in the washout period, A1C came exactly back to the starting point. And when they switched over, the other group went down. And again, the glycosylated hemoglobin dropped. And then, interestingly, the GOLD3 trial, the last one, demonstrated the same is true for hypoglycemia. This was, again, a hypoglycemia-centered study. And yes, with the use of CGM, hypo below 70 and hypo below 54 was reduced. And then the next question, very valid question, was, okay, we now have CGM, but we have to use it with SMBG, with self-blood glucose monitoring. Can we use it without? And this study that is called REPLACE addressed this question. And there were two groups. They were randomized to either use of CGM with SMBG and the use of CGM without SMBG, so just CGM. And what they nicely demonstrated is that there was no difference in between the two groups. So here, as you can see, CGM only and CGM plus blood glucose monitoring, no difference. This is the time in range here, and this is time in hypoglycemia, and the next one is time in hyperglycemia. So the study demonstrated that even if you use the CGM alone, you're as successful as if you use it in combination. And as you know now, in the United States, you already have 2 meters, actually 2 continuous meters, that are actually licensed by the FDA without the use of blood glucose testing. So it's Libre and it's the G6 from Dexcom. Is Dexcom available in Russia? No. Okay. And then this the Commissar study. It's an interesting study. I love the name Commissar. It's such an easy name to remember. The problem of this study was that only very few people were enrolled. So there are 15 people. It's almost a, a pilot study, more or less. 15 to 20 people in each group. And they demonstrated actually that CGM does the difference. But if you use pump in addition to CGM, you do even slightly better. Interestingly, a similar study, just with better numbers, if you want, it's a retrospective analysis of almost 400 patients, also demonstrated actually an incremental improvement in a retrospective analysis when you use the pump. This is the first line is nothing, second line is the pump, and the third line is pump and CGM, MDI and CGM, the fourth line is pump and CGM. So nice incremental improvements when you add technology one to the other. And interestingly, I'll just focus to the right-hand side here. Please see that diabetes-related emergency department visits decreased very significantly. And this is related to cost. And we will discuss this slightly later. So CGM can immediately reduce cost because of the reduction of emergency department visits. And finally, probably the most famous hypoglycemia study comes from Germany. So they were specifically selected the population that is hypoglycemia prone. And this was published half a year ago in the Lancet. They actually used CGM definition of hypoglycemia. So you had to have at least 30 minutes below the threshold to actually call this a hypoglycemic event, which is demonstrated in this graph. And yes, in this group actually you have baseline on the left-hand side and follow-up phase, so the treatment phase on the right-hand side, and you can see the huge difference in hypoglycemia, so low glucose events, if you want, in between the control group and the RT-CGM. This is also shown in this graphical way. So you have control group on the left-hand side and CGM group on the right-hand side, and you see the huge shift of the hypoglycemic events towards the left, and this is the reduction in hypoglycemia. Here, another way to present both severe and coma were reduced with the use of CGM. And finally, there is no data on preschool children, so we did a retrospective study actually in preschool children, and we're also able to show that with the use of sensor, actually the glucose variability, here is the coefficient of variation, is reduced in this preschool population. And also A1C can be improved. So here is the standard deviation and the coefficient of variability difference. And here is that if you use it frequently, which in this case was more than 5 days a week, also glycosylated hemoglobin is reduced in preschool children, which is a very, if you want, a sensitive group, of course, particularly because the fluctuations of glucose are likely very, very high in this young population. Finally, maybe the most important part, which is pregnancy. How many of you treat pregnancy with diabetes? Can you please raise your hand so that I see? I know you do. Oh, quite some. Okay, so you're probably familiar with this study. So this study randomized pregnant women to CGM, or the standard of care. As you can see, it was a very significant difference in A1C. But what's more important is that the time in range, and here please be careful, time in range is 63 to 140, so very stringent time in range, was significantly increased. So actually, in the CGM group, it was around 68% of time in range, with this very stringent range that is only valid for pregnancy. What's probably more important is that these hard outcomes were achieved. So large for gestational age, where it was reduced, hypoglycemia requiring infusion was reduced, and the ICU, the intensive care necessity, was also reduced. And on your right-hand side, interestingly, you do not, this is how many you need to treat in order to get this effect. As you can see, these numbers are rather low. So you need 6, 8, and 6 women to treat actually to get a significant effect on the outcome of the newborn. So a very effective approach, if you want, for pregnancy. Here actually the admission days, as you can see, so the hospitalization admission days significantly reduced in this study. And here, type 2 diabetes, there is much less data for type 2 diabetes, but there are two big studies, randomized studies. I only focused on randomized trials. They demonstrate actually also benefit in type 2 diabetes. So here actually device initiation, so it was a running period. And then actually there was weeks 4 to 12 where they analyzed the effect of CGM. And they didn't exaggerate with visits. They wanted to mimic real life in type 2 diabetes in this particular study. As you can see, actually, the usage was very high. So most of them were using CGM more than 6 days a week, so high usage. And this is the effect. So this is the baseline. This is week 12, and this is week 24, so half a year. As you can see, the A1C significantly lower with the use of CGM as compared to the standard of care. So similar success, maybe a little bit less pronounced than in type 1, but very similar success in type 2. And here actually also the same story, so the higher the initial glycosylated hemoglobin, the better the outcome, which is also seen in type 1 diabetes. And here you have actually time in range in minutes per day baseline, and actually the end of the study, so half a year, and you have time in range, time below range, and time above range. As you can see, time in range and time above range were both significantly improved. There is another study published recently as a review actually of other studies here. And as you can see, either they included all trials in this slide, or they included randomized controlled trials only. In this slide, you can see that there is a net effect of approximately 0.3% in glycosylated hemoglobin in type 2 diabetes with the use of CGM. What happens when you couple the CGM with a pump into a logical system? I saw outside that you have the 640G pump available in Russia. How many of you have experience with 640G pump? Can you please raise your hand? Couple? Okay, it's coming. So here actually we recently did a study, again focused on hypoglycemia, and we demonstrated that this system with predictive low glucose suspend very efficiently reduces hypoglycemia, at the same time increases time in range. Similarly was shown with another system that also have the same predictive low glucose suspend modality, almost as efficient as previous. There is now implantable CGM. It all started with Senseonics actually, so this is now acquired by Roche. And the first studies were promising, but this is now the big American study, the PRECISE-2 study. And here, as you can see, the MART is almost unanimously below 10. So this is quite impressive. And I have another very recent study actually published this January. Very similar results here. They looked the different days from day 1 to day 90. As you can see, MART actually, even at day 90, remains below 10. MART is actually, as you know, the measurement of precision, if you want, in a way, of this sensor, when compared to the standard glucose measurement. And also, interestingly, in the hypo range, if you look to the graph, to the table below, also in the hypo range, MART, again, is below 10, which will be the new FDA standard for continuous sensors. So these implantable sensors perform rather well. I promised you a little bit on cost effectiveness. And here I think the best study is this one from Belgium. Belgium insurance system actually required this study, and they followed up 500 people that were put on CGM and the pump for 1 year. And not only they observed an improvement in glycosylated hemoglobin, but what's more important actually is they recorded an improvement in quality of life, and they recorded an improvement in absenteeism from work. And out of this, actually, they were able to calculate a reduction in cost. So a cost saving of 345,000 euros in 1 year for 500 people in this study. So this was actually, so the use of CGM made the system cheaper, saving money. You often hear, yeah, this is so expensive, nobody can afford it. It's interesting, but when you put the total cost in the same year together, you save money when you use CGM. I know it is a little bit difficult to persuade insurance systems to believe you. I have the same problem all the time, but this is basically the study and the calculations. Interestingly enough, when the Japanese did a similar assessment of how much cost actually is hypoglycemia, they realized that with the use of CGM, if they transfer the Belgium data to Japan, they could save 4.5 million euros a year. So it's a very considerable saving, and this is why in the European Union and the United States, CGM is becoming reimbursed on the regular basis. Not because these people are so good-hearted. Insurance systems are never good-hearted, at least in my experience. But they basically realize that they can save money with this. And that, of course, is very interesting for the insurance companies. I will just touch closed loop and advisors in this lecture. I will speak more in the next one. And here, actually, this is Ljubljana. So this is my hometown. As you can see, it's a small town. It has a castle from 11th century on top of the hill, and the river around, and the river is tiny. When I compare to your river, actually, it's not even a creek. And there are some old houses. My city was established by the Roman Emperor Augustus in the year 4. So it's at the moment, it's 2014 years old. A continuous history that is actually in many Roman buildings in the city. And interestingly enough, the first closed-loop meeting was also held in Ljubljana many years ago. I will just jump to what we have at the moment. So this is actually the 670G that is FDA and CE approved. It's a hybrid closed-loop that actually, when in auto mode, so when used as a hybrid closed-loop, when used in automatic mode, it works best. It can keep time in range best. And I will discuss maybe a little bit why I emphasize this. I will finish with a case. So this is Anna, has type 1 diabetes for 12 years, was on a sensor-augmented pump for 6 years on a 640, and uses gluco. She's a happy young lady and does very well. She switched to hybrid closed loop 3 weeks ago. And this is her download. So what do you think? She does have type 1 diabetes, you have to believe me. And when you do the analysis here, as you can see, actually, she is here on the right-hand side. The first line says auto mode. You see auto mode per week, the upper line. So she is 99% in auto mode. 99% of her time, she's on an automatic closed loop. And with this, her time in range is 89%, believe it or not. So 89% of time, she is within the range. So just to tease you a little bit how this hybrid closed loop works in a routine girl. Not everybody is like this, of course. But also this is possible. And this is her day-to-day download, just to show you that still when she eats too much in the evening, if you look at the pink is the automatic insulin delivery. Look how much insulin the system is pumping in order to normalize the overnight glucose. You know, big meals, particularly in girls with diabetes, evening meals are often a problem. So for the first part, I would like to propose to you a couple of conclusions. First one, pump improves glycemic control and hypoglycemia. is associated with reduced chronic complications, which is very interesting. I showed you 2 studies about it. I didn't show you data, but it significantly increases quality of life. CGM, standalone or in a sensor-augmented pump, improves again glycemic control even further, even better, reduces hypoglycemia, improves pregnancy outcomes very importantly, and it also significantly increases quality of life. And closed loop and advisors, I will speak about advisors later. You started Vadim with them. I will tell you a little bit about. So they are actually here in routine practice, and new options are coming, so we will have a choice on how to proceed with a closed loop. And finally, just to introduce time in range, a new clinical target and a new clinical marker, and we'll discuss more very soon about it. This is just another way to use a CGM. But I have to warn you that this is an off-label use. With this, I invite you to Madrid. Next ATTD next year will be in Madrid in February. Many new results will be presented, particularly on technology and new drugs. Please come. And with this, I thank you very much for your attention. This is my team. They have to work while I speak. Thank you.
Well, dear Patrick, thank you very much for fantastic.